Hello again. In this presentation, I'll make it a bit light. I'll focus on some cases and then put a recommendation after each case. So I'll be talking about the collaboration between us as a radiation oncologist and radiology, and how crucial is this collaboration and being in a close communication and contact for each patient. So when we talk, as I mentioned in my previous presentation, modern radiation therapy relies on precise tumor localization for effective treatment. So as a radiation oncologist, we heavily depend on images for our treatment. So with advancement in technology, so we are able to fine-tune our radiation dose around the tumor, and we are able to spare the organ at risk. So we depend on image interpretation. This introduces variability in treatment planning. So here comes the radiology role in reducing this variability and making and the role is very crucial from the day one of the treatment. So radiologists are considered as a key team member in head and neck cancer MDTs, and interdisciplinary collaboration enhances tumor precision, safety, and outcomes. So the role of diagnostic radiologists starts from the day of the diagnosis and continues throughout the journey of care, and so that the continued communication between radiologists and radiation oncology is a necessity. So it starts from the day of the diagnosis, staging, treatment planning, assessing the patient while on the treatment, and also to monitor the treatment, response afterwards. So as I mentioned, I'll go through some cases starting from the baseline and then during the treatment and after the treatment and in long-term follow-up. So when we talk about baseline, this is just a highlight. We talk about diagnosis, staging, and treatment planning. The radiologist's role helps in identifying the tumor size, morphology, the extent of the disease. It helps in standardizing the staging for us as a radiation oncologist. So in terms of staging, I just got this from the last patient I had. And we are lucky in our center that the radiologists, they give a good description of the extent of the disease, and they give us a good staging for each head and neck cancer patient. So we are lucky in our center to have this. So I will start with case one. It is a 64-year-old gentleman with a diagnosis of T4N0M0 nasopharyngeal carcinoma. He had his baseline MRI that showed large nasopharyngeal mass on the right side, encroaching upon the parapharyngeal space with subtle erosion of the anterosuperior aspect of the clivus, encasing the ICA with widened foramen lacerum and involved up to the Meckel's cave. So the plan was to start with 3 induction cycles of chemotherapy followed by radiation. So the patient had a partial response. So contouring this case after induction, I'll say from the beginning is challenging. And imagine how it is challenging contouring this case after induction chemotherapy. So we were in close contact with our radiology, so we're able to identify the response after induction chemotherapy. So we're able to put our post-chemo GTV, and we take into account the pre-chemo GTV in our volume. And in these critical cases, your target is in very close proximity to the organ at risk, especially the brainstem here. So we take from this case that assessing tumor infiltration as well as bone involvement is challenging, and delineating near the skull base neurological structures and intracranial regions is complex, and it is more difficult after induction chemotherapy for us. So radiologists aid in the precise tumor delineation on the contrast-enhanced CT and MRI, which will help us in achieving a better local control. So luckily, this patient, after a good collaboration, we achieved that this patient is now 3 years post-treatment, and he had a very good response to the to the treatment he had. So in this paper, it is a base peer review of the impact of a new radiology on head and neck radiotherapy target delineation. So it was done over a 7-month period, 80 cases, and undergoing definitive 48%, post-operative 52. Head and neck radiotherapy, and they were reviewed during weekly treatment planning, quality assurance sessions between radiation oncologists and neuroradiologists, and they found that there is a 55% of the cases had their treatment plan altered after this collaborative review, and among the altered cases, 61 involve a clinically significant modification, such as a gross or residual tumor identification or elective in terms of post-operative coverage adjustment. So moving to the second case, it's a 70-year-old female with a lesion at the anterior two-thirds of the tongue extending to the floor of mouth, confirmed as a squamous cell carcinoma. She underwent total glossectomy with supraomohyoid flap with neck dissection stage as T4A and 0. Her surgery done abroad. We don't have any preoperative images, and on the postoperative images, when she came to us, it's showing there is a suspicious infiltrative soft tissue mass in the left floor of mouth, extending to the left sublingual space and infiltrating through the left submandibular gland. So I'm sure you can appreciate here the extent of the disease, as well as the invasion into the mandible. And so given her age, she was unfit for another surgery, so the plan was to proceed with chemoradiation. So in this case, given the invasion into the mandibular nerve, we have to track the nerve down to the base of skull. So we needed the radiology help in tracking this nerve up to the base of skull. So this was the collaboration between us and the radiology in this case. So collaborative work helps in distinguishing tumor versus inflammatory changes. And the close collaboration with the radiologist is essential in assessing the tumor extent and distribution, especially in cases where there is perineural spread, where we have to track the nerve down to the base of skull. So precise tumor planning in postoperative cases is challenging, and it requires careful planning to minimize the risk of underdosing the tumor or overdosing the normal structures. This is again a systematic review and meta-analysis of 31 cases, and they assessed the plan with or without radiologists, and they found that the overall pooled rate of radiation plan changed was 29%, with the radiologist involvement in the peer review was associated with a significant increase in plan change to 49% in comparison to 25%. And the head and neck cancer cases had the higher rate of plan changes. So moving from baseline into during treatment, during treatment, the radiologists can help in conduct interval imaging in terms of CT, MR, and to evaluate changes as needed and identify early signs of treatment toxicity, for example, edema, infectious process, or edema infectious process. And also, it is very important to differentiate between tumor shrinkage, necrosis, and disease progression. So in our next and third case, it is a 61-year-old gentleman with a nasopharyngeal carcinoma, T1N3M0, who was planned also to receive induction chemotherapy, 3 cycles, followed by chemoradiation. So as you can appreciate, this was a T1 tumor, so we proceeded with the first 2 cycles of chemo. So after the second cycle, the patient presented with nausea, vomiting, effusion, dysphagia, and hyponatremia, admitted to the ICU, and then the brain CT was unremarkable. Then we waited for about 10 days, and then he had an MRI neck that showed there is an inflammatory process with a suspicious disease progression. So this MRI was done in an outside hospital. So there was a discussion between the ENT there with the radiologist in that hospital, and then the consensus was this is a disease progression. But given the clinical picture, it didn't click that this is a progression. So Patient is responding locally, but there is a progression in the primary side. I mean, there is a response in the nodal side, which is the heavy nodal disease, but there is a progression at the primary side. So the ENT was insisting, so they took the patient and they did a biopsy, which came back negative. So the patient came to us and we did a repeat MRI that there is, and after 3 weeks, it showed a minimal regression of the retropharyngeal inflammatory changes. So after several discussion with our radiologist, it was decided that it's better to proceed as this is only inflammatory changes, and we proceed with our plan with chemoradiation. So the patient did not get his third cycle of chemo, and we proceeded with the treatment. And this patient is undergoing radiation, and on the picture on the left is our CT simulation, and the cone beam on the right, and we can tell there is a response or there is a regression in the inflammatory changes, and the patient is doing well now while he's on the treatment. So discussion and communication help in differentiating post-treatment changes from disease progression. In this case, collaboration prevented unnecessary treatment delay that could happen due to misinterpretation of imaging findings, and the clinical judgment should always complement the radiological opinion. We should always keep this in mind to ensure accurate decision for the patient. Our fourth case is a 61-year-old gentleman who is a known case of tongue cancer, underwent hemiglossectomy with a flap reconstruction and radical neck dissection as T3 and 2A. He was planned to receive radiation, 66 grain, 30 fractions. However, after 8 fractions, he presented complaining of left neck swelling, and the mask was not fitting. In addition, the cone beam CT showing there could be some progression in the submandibular lymph node, despite the post-operative MRI showing it's only inflammatory lymph nodes. So the progressed lymph node, we're reviewing the plan, and which showed that the progressed lymph node were not covered in the target volumes. So I'm sure this is cone beam CT we had. It's not that best quality, but when we reviewed all the slices of the cone beam CT, the level of suspicion of this increased size of the lymph node suggested of disease progression. So we had to adjust the plan and and added chemotherapy as well. So we have to keep like in these cases, we have to keep in mind, as well as in the next case I'll mention, that having a basic oncological knowledge or a background is very essential when we interrupt images for patients, for such patient, as this will alter the plan. So radiation therapy is an image-guided treatment. So precision of radiation heavily depends on radiological accuracy. Misinterpretation of radiological images does not only affect the patient outcome, it also lead to unnecessary resource utilization. Replanning requires treatment interruption, which affect the control of the treatment. So when we had such patient, we have to stop the treatment. We do a new plan, which maybe takes 3-4 days, and this is affect the overall prognosis of that patient. So when we talk after treatment, always is about post-treatment response evaluation, about recurrence, detection, and toxicity assessment. Perform imaging in terms of radiology. They perform imaging to assess residual disease versus post-treatment changes. Identify radiation-induced complications such as necrosis, fibrosis, soft tissue changes, and I'm sure they use their functional images to assess for any residual disease. So our fifth case is a 49-year-old gentleman with a known case of tongue cancer post-hemiglossectomy with neck dissection and flap reconstruction T4 and 1 with perineural invasion, who received post-operative chemoradiation afterwards. So his first MRI assessment, he was treated abroad. When he came back, we did our first assessment here in Kuwait. So it showed ill-defined abnormal signal intensity, soft tissue thickening at the left submandibular region, extending to the adjacent left carotid sheet, showing intermediate signal intensity in T2, hypointense signal in T1, with a foci of diffusion restriction with a granulation tissue 1.8, 2.3. On the PET scan, there is increased FDG uptake in the left cervical region with SUV 4.5. So the initial advice, do ultrasound. So we did ultrasound, it was unremarkable. So we discussed this case in the MDT multiple times. It showed with the nuclear medicine, the consensus was, no, this is post-operative changes. Let's repeat the MRI in 3 months. After 1 month in clinic, the patient came with left-sided facial and jaw pain, with swelling, neck pain, left-sided headache. So we said, let's do a repeat MRI. And on his repeat MRI, it's showing there is interval progression of the previously seen ill-defined heterogeneous abnormal signal intensity soft tissue thickening. And now it is encasing the carotid as well as, and this is suspicious for disease recurrence. So on the PET scan, there is also increase in the FDG uptake to 8.2. So the patient travel abroad. But from this case, we have to take into account, as I mentioned, that there should be some oncological background when you interrupt such images, interpret some images. Because this patient with locally advanced lung cancer, with perineural invasion, we have to make our level of suspicions very low. So if this patient would detect that this is a recurrence earlier, the plan of management would be changed. So earlier detection of recurrence is very important, especially with emergence of a new treatment modalities and of what we are doing. And having a basic oncological knowledge or background is essential for radiologists, as it can alter for a more careful interpretation of post-treatment changes versus suspicion findings. So this patient, another patient, she's a T3 and 0 larynx patient. She came in to us with complaining of dysphagia. She was admitted in the ward, and we did reassessment for her after 6 months of treatment, and we received this conclusion. It is, I understand, sometimes very hard to interpret imaging due to motion artifact, but when you get that this is post-treatment changes, but it could be also some residual disease, it will put us in a corner where we don't know what to do with such patients. So it is understandable that the radiologist and radon cannot interact closely, but when you see such images, there should be good communication between us to reach a consensus that will be extremely helpful for us and for the patient in taking such decision about what is next step. So in terms of long-term follow-up, so it is mainly for surveillance, late toxicity monitoring, and secondary malignancy detection. As a radiologist, they do periodic imaging to detect recurrences and monitor changes in the irradiated area for long-term effects and identify any radiation-related complications. So in this case, this is a tonsillar cancer, T3N1M0, treated with concurrent chemoradiation. And the patient was doing well post-treatment. First 6 months, he was doing well with excellent treatment response. And at his first year of a treatment, he had both MRI and PET scan. So here is his MRI at 12 months, showed it's only post-treatment changes. No evidence of disease recurrence, and in a week he did his PET scan that showed there is a new multiple focal hypermetabolic soft tissue in the nasopharynx, right retropharyngeal space, and in the lymph node, and it is suspicious for recurrent disease. So the patient got confused. And it's very obvious there was no collaboration or communication between nuclear medicine and radiology. They did not look at the images. The nuclear medicine. They did not look at the MRI. So we had to do collaborative work together. We put them all together. We discussed it in the MDT, and then it ended up to be only post-operative changes. So this is 18 months after treatment. It's showing post-treatment changes, and this is just last month. It's showing that even the PET scan finding, it was only, it is all gone, and it's suspicious only for post-operative changes. So we have to keep in mind that the communication extends not only between us as a radiation oncologist and diagnostic radiologist, it also effective coordination between radiologists and nuclear medicine is also very, very essential to ensure consensus on the patient status and eliminate any potential confusion. So to conclude, dedicate time for discussing challenging cases to enhance decision making is very, very important. We have to streamline radiation planning. So structure collaborative workflow between us and diagnostic radiologists is also important to have a very precise treatment plan, and the patient care relies equally in all team members, and this is a shared responsibility between all of us as a team. Multidisciplinary collaboration and to achieve an effective treatment requires active participation from all the head and neck team, MDT team members. And I think what is good is we standardize a communication between us as a radiation oncologist and diagnostic as well as nuclear medicine in terms of doing a clear protocol to enhance interdisciplinary collaboration and decision making beside the head and neck MDT. And thank you very much.